Good afternoon, everyone. My name is Abdulnoor Hassan, Clinical Application Specialist for Mandre in Africa and Middle East region. It's my privilege this afternoon to be the moderator for the Ultrasound Series CME courses collaboration with the Ethiopian Society of Obstetricians and Gynecologists. Our speakers today are very known to us. Here we have Dr. Huang from China and Dr. Abdul Fattah and Dr. Fikre from Ethiopia. Our agenda today will be like this. First, we are expecting Dr. Abdul Fattah to give us a brief opening remarks. Then our main speech, the role of ultrasound in gynecological surgery by Dr. Huang, and enhanced recovery after surgery by Dr. Fikre. And of course, at the end, we will have the Q&A sessions. But first, here is Dr. Abdul Fattah to give us a brief welcome opening speech.
Okay, dear ESOG members and residents from different OBGYN institutions, welcome to our learning session, which is going to be very important and exciting. This session has been organized by Ethiopian Society of Obstetricians and Gynecologists, ESOG, in collaboration with Mindray. Mindray is a very big company producing different medical equipment. So one of these equipment is ultrasound. They have a very serious types of newly produced ultrasound with different technology. So you know that ultrasound is our stethoscope in day-to-day our practice. So having said this, today we will have two speakers. The first speaker is Dr. Jin Huang, who is an associate professor, associate consultant, working as a deputy chairperson of the Department of Obstetrics and Gynecology in the third affiliated hospital of the Chinese University of Hong Kong, located in Shenzhen, and also she is an adjunct chairperson of the Department of Gynecology in the first affiliated hospital of Chongqing Medical University, Nanchuan Hospital. She has research interest in reproductive medicine, early pregnancy, recurrent abortion, reproductive failure, and reproductive surgery. She has published about 25 papers published in different international journals. She has also 2 English book chapters. So she will be presenting to us the role of ultrasound in gynecologic surgery, and she will be also sharing us her experiences while using ultrasound, having different interventions of gynecologic cases. So it will be very exciting. The second speaker will be Dr. Fikre Garamo, who has finished his undergraduate school in Addis Ababa Medical School, and he has completed his residency program in St. Paul Hospital. Graduated in 2009, so he has been working for more than 4 years in different hospitals across the country, in Gambella Hospital, in Borona Primary Hospital, Addis Ababa Fistula Hospital, and the Dama General Hospital Medical College. So now currently he is in Gambella Hospital, so he will be sharing us his experiences in enhanced recovery after surgery. So what interventions should be performed to have enhanced recovery after surgery? So he has very important experiences to share with us. So maybe to have to change our experiences in the coming years to come. So having said this, I will invite the first speaker, Dr. Jin Wang, then Dr. Tukre Garamo will follow. So enjoy your learning sessions.
It's my pleasure to be invited by Dr. Abdulfak and also to join this CME meeting and to talking about the theme of the URAS and the relationship with ultrasound and the gynecological surgery diagnosis. And I think this is a very big topic and a very nice topic, but we will focus first on ultrasound, and then the next speaker will talk about the URAS. So thanks for the invitation again. And my sharing with you is the role of ultrasound in gynecological surgery. So in this topic, we will cover the following contents. First, the introduction of the ultrasonography application in gynae surgery, and also to explain some state-of-the-art technology which may help with the hysteroscopy. I think maybe most of the doctor will do the hysteroscopy by yourself. And also, I will share you some special cases that is related with the ultrasound application in gynae surgery. First, let's see some of the history. The ultrasonography is first used in the during the late 90s to the early 20s in industry, and because of the physics, you know, the basic the work thesis of the ultrasound is we will detect the difference between different surface. If the content is different, so the ultrasound echogenic materials are different, the ultrasound will have some of the difference that will show in the machine and let us know the wave are changed. So in the mid-90s, this doctor, who is our gynae doctor, OB/GYN doctor, Dr. Ian Donald, introduced the ultrasonography into the OB/GYN application. So now we also have a school, which is called the Ian Donald School, which is aimed at training the OG doctors to be a master of the ultrasonography, because it is really very, very useful in our OG clinical setting. And these are the ultrasound machines which are in the museum, and it is history that we can see the ultrasound machines before are very huge and seems not very smart, but it is the development of the technology which makes the 4D ultrasonography now is applicable to the clinical settings. So that is the kind of ultrasound scanning we can do now. Later I will introduce to you. And talking about ultrasound, we will use different props. The props are depends on the body, the which of the location or what kind of organs you are trying to detect. So the props that we use for the OG settings are mainly two kinds of props. The first kind is for transvaginally scanning. The second kind of prop is for the transabdominal scanning. And the transabdominal scanning is in the short form is called TAS, and the transvaginal scanning in the short form is called TVS. So during the TAS, doctor will put the probe in the patient's abdomen, and this is the picture we can see during the TAS. And this is the bladder. Bladder is very much important in the TAS because it gives us our echo window that for we to see the organs behind the bladder, that is the uterine or the ovaries. So if for TAS, if there is no bladder with the fluid, that means the urine, there is no urine in the bladder, we cannot see the uterus or ovaries clearly. But for the TAS, we don't use this because we put the probe into the vagina of the patients, and you can see that the probe is very much close to the organs that we are going to see. So the TBS has its advantage that it can see the organ very clearly without any other kind of windows that we need to use. So you can see this is the middle sagittal view of the uterus and the cervix, and this is also the middle sagittal view of the uterus and the cervix. That's the difference between the TS scanning and the TBS scanning. So in the TBS, that this is the very common use in I think in the OG area, that in the TBS, you can see this is the middle sagittal view, and also this is the transverse cut, this view of the uterus. And this is a uterine cavity with a very thin line. And also this is the TBS that we use the 3-dimensional reconstruction. And you can see this is the uterine cavity, that is the endometrium. So for this kind of view that we can hardly cut by ourselves, no matter how you put your probe, if the uterus is in their normal anatomic location, it is very hard for your probe to cut this kind of section. So you need the 3-dimensional reconstruction technology to help you to make this kind of picture come to your eye, and which is very easy for the junior doctors to recognize, oh, what's the structure of the true organ we want to see. Before, I think some of the doctors think, I think 3D ultrasound sonography is a kind of toy. It is a kind of selfie or a kind of funny pictures we made and to show to the parents or the ladies that would like to see the baby's face. And so we use the 3D ultrasonography. In fact, the 3D ultrasonography is quite useful. It's not just a funny toy or making beautiful pictures, because from this picture you can see for some of the malformations, it is very easy to get the measurements. If it is without this kind of reconstruction technology, we cannot have this kind of measure in 2D TBS. So another technology that is related with ultrasound is the construct imaging. What is a construct? Usually we can use the negative construct, that is normal saline. Why it is called negative? Because from the bladder, from the TAS, do you remember the bladder is black? So because of the normal saline, the water is not echogenic. So usually it is black in the picture or in the monitoring that we see. And for the positive contrast, it is echogenic small bubbles or fluid. So most of the time we use, now we use the lipid microspheres, which I have heard that in your place, this kind of contrast is not available now, but believe me, it's quite useful if you want to do some some contrast imaging with ultrasound. Both the normal slide that is the negative contrast and the positive contrast are very much useful according to different situations. So talking about the contrast, how we use this contrast, we have this tube first put into the uterine, and this is a uterus, and this is a fallopian tube, the ovary, and then we put this prop in. The prop, the tube is a little bit like the tube that we use for the urine, So this one is a small bubble that we can inflate. After inflate, it is stay here, and then we get some of the contrast. This is an infusion tube, putting the contrast into this tube, and it will go into the uterine cavity as well as the fallopian tube. Because the fallopian tube is not seenable under the ultrasound. Usually, if it is not have some abnormality, the fallopian tube is very hard to see. So after you put some contrast, no matter it is negative contrast or positive contrast, this tube is seenable. So that is very useful for the technology that is we call HyCoSy, that we will talk about that. And so this is the picture that we do the normal saline infusion, which is called the saline infusion sonography, in short form SIS. See, the normal saline under the ultrasound is black. So usually the uterine cavity is closed by itself. It is a potential cavity, but after you put into some normal saline, the cavity is very much clear under your ultrasound probe. It's like this. If we detect this a little bit malformation, maybe it's briefly it is a normal uterine cavity, but you can see the very small changes of the uterine cavity. If it is under the 3D scanning or 2D scanning, you cannot detect this. So that is why the negative contrast is a very good material, and this is SIS is a very good technology for you to detect uterine cavity abnormality. And for the positive contrast, that is the small bubbles, which is quite very much echogenic. When you put in that, see, you can't see the uterus, you can't see the ovary, but you see the cavity, because other tissues are not as echogenic as this one. So you cannot see others, you can only see the cavity. This is the uterine cavity. Under the normal saline, it is black, but with this echogenic contrast, it is very bright. And you can see the fallopian tube. So this fallopian tube, we know it has some problem because the contrast all goes to this part and didn't split into the pelvic place. And also for the left part, we cannot see the fallopian tube. So this is an abnormal fallopian tube. Maybe for this case, the left fallopian tube has already been cut during the previous surgery of ectopic pregnancy, but this one is a kind of blockage. So that's why this patient came for infertility for the treatment. And this is for the technology that is called HyCoSy hysterocontrast sonography. So much for the fancy technologies about the recent ultrasound development. And also we make some diagnoses which are quite useful. Even for the 2D TVS, the 2D TVS is clear enough to see there are some problems, right? You can see that this is the middle sagittal view. And if you still remember the picture I showed you previously, that for this uterine cavity, it should not look like this. It should at least look like a line or a thin line, a thick line, but not like this. So this is our what? This is the plot, the endometrial plot. And if we add some vessel flow, we can see, sometimes we can see there is a feeding vessels into the plot. But 2D is not the best. You can see 3D. 3D can see even more because 2D is just like cut the uterus into slices. But for 3D, it can see the whole uterus. And this is a multi-flops. So this is the big one, this is a small one, but still it's not very clear. If a doctor had if it is a medical student who had no training of this, the picture is still a little bit difficult for the student. But if we look at this, I think even layman or patient herself could understand, oh, this is the problem, and this is the uterine cavity, and this is the biggest one, that is a problem one, and these are still small ones. So this is a multi-endometrial polyps. So this patient, what we use to make the picture so beautiful is we use a very easy find material, the negative contrast, that is the lomosine line. So we use the SAS and the 3D technology to make this picture beautiful and very easy to diagnose the problem. It is even like the hysteroscopy, but we can see the whole uterine cavity. And also for the diagnosis of the fibroids, if we just look at the 2D TVS, oh, there is some problem and there is a small fibroid. And this patient is, of course, she is very easily suffered from maybe a huge bleeding. But we don't know, for the doctor, for the surgeon, we don't know whether this is a very easy removable fibroid, right? For doctors, you need to consider whether this surgery is difficult or not. Do you need many or a lot of preparation before you do this surgery? After a little bit of the lomosine line intubation, we can see it is a very easy surgery because the basement is very thin, very small, and it is very easy to cut during the hysteroscopy. If it is like this and the base is very wide, and this surgery may cause quite a lot of bleeding. So before surgery, the diagnosis and the assessment of the surgery is very much important. And of course, for diagnosis of the uterine anomalies, 3D ultrasound is very much helpful. Before we use the 2D ultrasound scanning, we can only use a very experienced mind to reconstruct the pictures in our mind. But now we can use the AI mind to use their 3D reconstruction technology. We know this is the problems of the different kind of the uterine cavity, which is very hard to diagnose only by 2D ultrasound. And of course, for the Asherman syndrome, for the adhesion in the uterine cavity, the ultrasound is not the best or the gold criteria for diagnosis, but because it's very easy to carry out, it could be the first scanning method we use. For example, this is a part of potential adhesion, and maybe these are areas which the endometrium is not smooth or it have some abnormalities. Maybe these are the places. But for the SIS, if we remember, the normal saline is a very good and cheap available contrast that we can use. If we use the normal saline, you can still remember the black triangle uterine cavity. So you can imagine that if there is any kind of adhesion inside that triangle black uterine cavity, it's very easy for the doctors to see. So you can see the data from the paper that the port sensitivity of the SIS is high, that for the SIS 3D technology to diagnose the adhesion, and the specificity is almost reached to 1. So that's a very good performance of the SIS to diagnose the uterine adhesions. But of course, the golden criteria is hysteroscopy, that you see the adhesion during the examination of the hysteroscopy, you know the diagnosis. So this is the first case I will share with you. It's very interesting. Before we do the surgery, we only know this information. First, this Madam X is 52 years old, and she has been menopaused for 3 years. So now she came for the IUD removal. That's all we know. And we have to do our 2D TVS for her. And I'm not quite sure whether the machine is okay or not, but the report is like this. The uterus is normal uterus, and the intrauterine device is tilted to the left. So we are a little bit suspicious when we see this. And the junior doctor who is trying to do this IUD removal, he didn't do quite a lot of preparation, but then she trying to do the removal, he thought, no, it's something strange. He can't put the hook inside, and it's very difficult to put the probe inside of the uterine cavity. So he called the senior doctor. And the senior doctors think, oh, our hysteroscopy is very handy, because in China, I forgot to tell you the background. In China, the OG doctors are quite happy, because they don't need to do the ultrasound scanning by themselves. They have the specialist sonographers to do all the ultrasound scanning for them. So usually the OG doctors will not do the scanning by themselves. But I'm a special one, that I have the training in Hong Kong. So like Hong Kong doctors, we do the ultrasound scanning by ourselves and also see the patient. I love the ultrasound scanning because I think it helped me quite a lot. So the cases are showing you some of the special cases that I met, that I thought the ultrasound technology is very useful. And so maybe like other doctors, I think it's very lucky that the OG doctors could do the scanning by themselves, because they can see the ultrasound is like an scenario, not just based on the health. Then we came back to this case, and the hysteroscopy just like this. Okay, so it is adhesion. The adhesion, we see maybe this is a place that we can try a little bit. But at this time, when I saw this, I remind the doctors who is doing the surgery, maybe our ultrasound, an ultrasound for you, if it is a TS, will help you to see whether you are going to the right place or not. But unfortunately, in most of the OG clinic settings, we may have the hysteroscopy but we do not have the ultrasound machine. So they doing the hysteroscopy and meeting with some of this kind of severe adhesion, but they do not have the ultrasound machine. And they are trying for this very carefully. And luckily, we enter into the uterine cavity, but see nothing. We can't see the triangular shape of the uterine cavity, right? It should be the normal uterine cavity. Oh, sorry. The normal uterine cavity should be like a triangular, and you can see the fallopian tube opening. That is the fallopian tube os. But this place are suspicious. It is like one of the, maybe the left one, the right one, sorry, the right fallopian tube os. But where is the IUD? And then we came back to the cervical place, the cervical os, and we find, is this part another place we should go in? And at this time, I seriously remind the doctor, can you call some ultrasound doctor to help you in case that you make the complications? That means to go out of the uterine, make some of the injuries. Still, there is no hope, and they try their best to get in. And luckily, we go into another cavity, and this cavity, we didn't see any bowel movement. If we see any bowel movement, that is a big problem. So we see the IUD there, and you can see that after we go into that adhesion place, in fact, the inside is okay, but later we find when we go further in, we see, oh, that explains why the ultrasound doctors remind us there might be some kind of adhesions because the IUD tilted to the left. So since we assess that this IUD, most of the IUD is not inside the uterine cavity, so we think this part of the adhesion is easy to remove. So we just pull this IUD. We are trying to pull this IUD out. You see, this IUD have been removed from the uterine cavity and gets lower. And this is a very abnormal uterine cavity because it has a septum here. And when we find a septum here, because we know that this lady has given birth to kids, she has been pregnant before. We asked her, and at this time, she told us, she said that, oh, I didn't tell you the previous history because I'm afraid you will not do surgeries for me. Because before, after I gave birth to one kid, I have been doing the abortion, the artificial abortion. During the artificial abortion in the first hospital, the doctor says, oh, it's very difficult. I cannot do because it's many years, decades before. The doctor says, it's very difficult to do. Maybe your abortion hasn't been finished. So you go to another big hospital to try this again. So the lady go to the second hospital, and the second hospital is trying to do the abortion for her, but with a very, very lot of difficulty and a lot of bleeding. So maybe at that time, the ultrasound technology is not that handy for the doctors to perform. So so the lady now, she is not worrying about the IUD can't remove, but she's worrying the doctors don't accept her, don't let her do this IUD removal. So she just hides the history. And after we remove this IUD, she's very happy and think everything is smooth now. So this is a very funny case without any ultrasound surveillance during the surgery. And later I will show you one very interesting case again with ultrasound surveillance. So for us, we doing the hysteroscopy, the key factors to avoid the complications is first, prevent uterus perforation, and second, to shorten the operation time. Because today we're talking about the EROS. The EROS is asking for a quick recovery for the patient after surgery. How to make sure the patient recovers surgery very quickly? First, we need to do our indicated surgery. And second, we need to do the surgery in a very careful way. If our very severe damage or complication happens after the surgery or during the surgery, no matter what kind of the EROS procedures you do, you will not help the patient recover very soon. So the diagnosis and as well as the surgery performance is very much important for the recovery of the patients. So this is a very common that previously, if the doctors doing the hysteroscopy, they do not use any kind of monitoring to help their especially when they are doing some dissection or cutting in the uterine cavity. If they do not have any monitoring, this kind of perforation will happen. So now, if we do our any kind of dissection, especially with this kind of very severe adhesion, the Asherman syndrome, we will definitely use the ultrasound for the monitoring. So you can see, you cannot even see the normal uterine cavity. There is no cavity, and you cannot see the endometrium. Maybe in somewhere here, there is a little bit endometrium, but others, these white tissues, the white fiber tissues are all adhesion tissues. So you can see from the ultrasound, we are very safe. We feel very comfortable if we do any cut or any movement under the surveillance of the ultrasound, because we know we are in the normal direction, and this part with many bubbles, that is because they try in the wrong direction. And it's lucky that we are under the surveillance of the ultrasound. We know it's wrong, so we will go into another direction. And for the perforation during adhesion dissection under hysteroscopy, there are some of the publications that we can see the case numbers are not very low for the adhesions. In fact, the perforation all means that very mild one, or maybe not as severe as the case I showed you previously. The perforation rate, in fact, is very low, only 1.7. Especially for the mild one, if there is a small band, you can just use your chalk or the shield of the hysteroscopy. You can just remove the adhesion. But for the severe adhesion, especially when you use the scissors or any heat devices to cut the adhesion, the perforation rate increases quite a lot, right? So far, do you have this kind of question that for the surveillance or for the monitoring of the hysteroscopy, which one do you prefer? Do you prefer the laparoscopy to monitor, or you use the ultrasound for your monitoring? Because someone have asked me this kind of question before. So I will let you to think by yourself. But my opinion or my clinical practice is that I will definitely choose the ultrasound to do the monitor. Because why? Because for laparoscopy, most of the time you can only see, oh, sorry, I have already done the mistake. That is the only result. You cannot prevent. For the ultrasound, you know, oh, it's getting close to the outside of the uterus, getting close to the mucus layer, no come back. Usually the one who is holding the probe monitoring for you when you're doing the hysteroscopy, they will tell you, hey, stop, you are coming very close, you are dangerous. So, but for the laparoscopy, no one can do that. Only when you come out and let others see you, they will say, oh, sorry, you already performed, right? So I will choose ultrasound. And the second case is also very interesting. That is another Madam X who is 31 years old, who have pregnant twice and have one kid. And she is suspected of corneal pregnancy and under the scanning of a 2D ultrasound. So for this kind of corneal pregnancy, maybe most of the doctors understand that it is our umbrella term. That means it's not a diagnosis because they don't know whether the pregnancy, the pregnant sac is inside the uterine cavity or into the fallopian tube, which is very much close to the uterine cavity. So they only give a very blur area that is in the corneal. So that is why the corneal pregnancy is called, but it's not our diagnosis. So the initial management for the doctor who receiving this patient is they decide to do the dilation and the curettage, and then under the transabdominal scanning monitoring. It's very clever that they choose the ultrasound monitoring. But during the D&C, they think it's very difficult to get to the pregnant sac. It's very coming close, but it can touch it, but it cannot get it out. So they think something wrong. And during the TS monitoring, they think they are touching the pregnant sac, the product of the concept they are touching. So again, the hysteroscopy is very handy for them, and they use the hysteroscopy to check what's wrong inside. So because it is a little bit bleeding after the D&C, and they see this bulging part seems like our pregnancy, seems like the location of the pregnancy, but it's a little bit different from what they see before. If you have this kind of experience that you know for the pregnancy, it is there is a bulging out part of the sac, but the appearance is quite different. It has some very big vessels. It is looks like purple. It's not white, right? White inside is usually maybe some muscle fibers or adhesion fibers. So this is pink and white. And for the pregnancy one, it should be purple or a little bit yellow. It should not look like this. So they are just sit there thinking, what's wrong with this sac? And they are trying to use the hysteroscopy to touch this part. They just touch. And during the ultrasound surveillance monitoring, we see they are indeed touching this part is touching the pregnancy place. And then tried several times, even very close, but it's still very strange. It's not like the normal pregnancy one. So they call me again. And when I get to the OT, I saw this. I'm not quite sure whether you can appreciate the very tricky place. You see, this is the bladder, right? And this is what? This is a hysteroscopy, the lomosine line, right? And the negative contrast and the hysteroscopy they are using. And this part, did you notice that this part on the left side is very much suspicious? And if we look at one of the pictures that I cut from the previous video, this is the uterine cavity, and this part, in fact, a large part. The larger part, the major part, is not inside of the uterine cavity. This is the muscle, this is the bladder, and this is the mass. And this mass is in which part? Now maybe you can tell us. It is in the interstitial fallopian tube. Yes, this is the interstitial fallopian tube pregnancy. So that is an ectopic pregnancy. And of course, we cannot remove this pregnancy under DNC or under hysteroscopy, right? And during the laparoscopy, you can see this is the gestational sac, right? This is the problem. And it already a little bit broken lesion here, start to bleed a little bit, only a little bit. Still the main part is not bleeding, it's all there. So can you imagine if it is not without the help of the ultrasound and the doctor, if they do quite a lot of the cartilage, made it broken, the bleeding, I think it's very, very huge and in a very large scale and can't stop very quickly. It may even cause the uterus being dissected and removal if for the very huge one. So you can see the bleeding already starts and the gestational sac is quite huge already, and even make this layer very, very thin. So this is a very dangerous one. And after we do the diagnosis, well, in fact, to remove this is very easy. And why I showing you this surgery part is because that you can see during the removal of this gestational sac, we can even see the uterine cavity, because later you can see some of the water, the fluid from the hysteroscopy comes out. So that means it is very close to the uterine cavity, but it is still our ectopic pregnancy. And that is only because of the gestational sac is very big. It is very big. It extends to, it bulged to the uterine cavity. This is the uterine cavity already. So it is bulged to the uterine cavity, which made the doctor have the illusion that maybe if the ultrasound doctors do not tell the clinical gynae doctor to know the location, the doctors themselves, maybe they won't find this. They're only suspicious why this hysteroscopy or DNC is so strange. The feeling is so strange. Why cannot touch the gestational sac and remove it? It is because it's not in that location, right? So the removal is smooth and the bleeding is very controllable. Only maybe total only 20 milliliters of the bleeding. So the recovery of the patient is very quick. After this surgery, she's discharged from the hospital the next day, and the HCG decreases very quickly. And for the revisit in outpatient clinic, the recovery is also very good. But if this case, if the ectopic pregnancy broken, some part broken and bleeding and gets very huge bleeding, I don't think the recovery could be very quickly. Okay, so this is the last part we will remove. After that, we put this whole gestational sac, the part, into our plastic bag and then remove it. So, and then we close this part with stitches. So the recovery is very smooth for this case. And you can see the bleeding is only the oozing of the bleeding. It's not huge. Okay. So to share you with this technology and the cases is, I want to share you with a Chinese saying that is from 论语, which is the analects of the Confucius. That is, it is saying that 工欲善其事，必先利其器, which means to do a good job, an artisan needs the best tools. I think to do a good clinical or gynae job, to be a good gynae surgeon, the doctors needs the best tools, and of course needs to master the tools very well and to use it to help the patient. And these are, because I love ultrasound quite a lot, and this is the White Journal, and during the celebration of their 30 years birthday, they have this kind of art gallery to published in their special edition. And I also submit one of the special case. If you are interested, I will later share with you this case. And this is ovarian cyst, and later we found it is ovary cancer. So this is my email, and if you are interested, or if you have some problem you would like to discuss with me, you can send me email. Thank you. Thank you.
Thank you so much, Dr. Huang, for your enlightening presentation. Before we move on to the next session, please, if you have any questions, put in the chat box. We will answer them in the Q&A session. Now, let's welcome Dr. Fikre, who is going to talk to us about the enhanced recovery after gynecological surgeries.
Good afternoon. Today we are going to discuss on enhanced recovery after surgery, ERAS or ERAS. It has been being practiced in Western countries, especially in Northern Europe, like Denmark, for the last almost 25 years. It has been around for a while, but its practice worldwide is not that much significant. In fact, there is no any record of this kind of practice or any research that's done to show this practice is being done in our country. So it is one of the recent ways of doing surgery which eliminates the traditional practice of doing different kind of surgeries and management of pre-operative and post-operative patients. This is just an introductory. Outside of my presentation will be, I will be discussing on the objective, the introduction, and ERAS for Cesarean section, ERAS for gynecologic surgery, and there will be references we provided at the end. The objective is to introduce the concept of enhanced recovery after surgery to our members and to optimize patients before, during, and after cesarean section and gynecologic surgery, and to share my experience on enhanced recovery after surgery to ESOG members. And almost for the last 2.5 years, I have been practicing ERAS during my private practices. As an introduction, surgery will always remain a form of intentional injury. And this intentional injury results in collateral damage to normal tissues due to trauma-induced physiological changes, which are mediated by cytokines, nitric oxide, and free oxygen radicals. And there is a rise in circulating glucocorticoids, catecholamines, and glucagon that are counter-regulatory hormones, which is elicited by activation of the hypothalamic pituitary adrenal axis and the sympathetic nervous system. And the response is mediated by afferent nervous and humoral factors, including cytokines generated from the site of injury, that is the site of surgery. And mobilization of energy reserves promotes hyperglycemia and catabolism. In fact, surgical stress response results in hyperglycemia and catabolism. So what we do in ERAS is to alleviate this hyperglycemia and catabolism states. Hyperglycemia develops as a consequence of insulin resistance coupled with an inappropriately high hepatic glucose productions. So cytokines, they induces insulin resistance in peripheral tissue, and at the same time they increase the production of glucose in the liver. So this leads to hyperglycemia. And also proteolysis and lipolysis accelerate to provide precursors for gluconeogenesis. So all over the body, lipolysis and proteolysis will result. And the resultant amino acid influx also promotes the synthesis of proteins involved in acute phase response. So to schematically express what have I said, surgery is a stressor. So when we do surgery, the afferent and the sympathetic nervous stimulates from the site of injury through humoral and neural response. They go to the hypothalamus and pituitary, and they produce counter-regulatory hormones like cytokines, which leads to inacute phase proteins, which leads to glucolysis and gluconeogenesis, and there will be high amount of glucose in the vascular system. But because of the insulin resistant effect of cytokines, these glucose are not being consumed by our organs, so this leads to hyperglycemia. At the same time, there is whole body protein catabolism, which leads to proteolysis and lipolysis, which produces ingredients for gluconeogenesis, and glycolysis, which leads to hyperglycemia. And in fact, hyperglycemia is the hallmark of surgical stress, and it is one that we have to manage when we are considering enhanced recovery after surgery protocols. And however, there are multimodal interventions to combat the surgical stress response and are taught to reduce the deleterious effects of surgical injury, and which leads to enhanced recovery, decreased morbidity, and reduced costs. Traditionally, that was biological phenomena that happens after surgery, but traditionally, what we interfere during surgery, what we do during surgery, and most of them are not evidence-based, but what we do traditionally leads to different complications, like patients are starved overnight, they will be given opioid analgesia unnecessarily, there will be nasogastric suctioning, and we are liberal use of fluids after surgery until the patient passes flatus. So this leads to morbidity and mortality, and this will compromise the patient's outcomes. So to facilitate recovery, adoption of evidence-based perioperative practice is required. And these elements of best practice include early feeding, avoidance of mechanical bowel preparation, utilization of preoperative patient education, optimization of comorbid conditions, euvolemia, normothermia, and use of minimally invasive surgery, like laparoscopy, or in our case, we can, if we are not doing laparoscopy, we have to make the surgical incision appropriate, minimizing the incisions, and also prevention of surgical site infection and venous thromboembolism, and assurance of optimal pain control while minimizing opioid use, or by sparing opioid use in a patient undergoing surgery. And the cornerstones of enhanced recovery after surgery are evidence-based perioperative care. Whatever we do in preoperative period, intraoperatively, in the post-op period, we have to have evidence-based preoperative care. This traditional and dogma thinking should be avoided in the case of enhanced recovery after surgery. And multidisciplinary and multi-professional approach is mandatory. So the anesthetic, the surgeon, the scrub nurse, the ward nurses, the administration, everything, everybody involved in the patient care, and also those paramedics should be involved, and it is a teamwork. And also there should be continuous interactive audit and reporting. And whenever we change our practice, or when we add something to our practice, it should be data-driven change. And also we have to make ourselves ready for the next change. And whatever we do to ameliorate this kind of surgical intervention is called enhanced recovery after surgery. Some people call it evidence-based protocol or guideline. And the ERAS protocol, the aim is to standardize the perioperative care of patients. And the enhanced recovery system is an integrated multidisciplinary protocol to expedite postoperative recovery. And many elements have been adopted from other successful enhanced recovery after surgery programs, predominantly enhanced recovery after colorectal surgery. And colorectal surgery, and people were doing this kind of intervention in colorectal surgery when they are introduced enhanced recovery after surgery. As I said, the one who initiated enhanced recovery after surgery protocol was a colorectal surgeon who resides in Denmark almost 25 years back. And enhanced postoperative recovery programs, they were first described in colonic surgery in 1995. And the use of this protocol was first evaluated in colorectal surgery, which demonstrated a reduction in the length of stay, a significant decrease in complications, and a significant cost saving. And the ultimate goal of enhanced recovery after surgery is a pain and risk-free operation. Imagine if the patient is pain-free and risk-free if they are going to operate. So pain and risk-free operation is the ultimate goal of enhanced recovery after surgery guidelines or protocols. And ERAS, it is spreading like a wildfire across the world arena of virtually all surgical disciplines and anesthesia for good reasons. And it is, as I said, this is being practiced in different surgical disciplines. And when you come to our area, the American College of Obstetrics and Gynecology, they issued a committee statement on enhanced recovery after surgery protocols. Royal College of Obstetrics and Gynecology also, they published a guideline for the use of enhanced recovery after surgery. FIGO also recently published a paper about enhanced recovery after surgery protocols. So the world is using these enhanced recovery after surgery protocols in every disciplines of surgery. It results in a winner and at every stakeholder level. First and foremost, the patients who suffer fewer complications, experience faster recovery, and return to normal functions and everyday life activities quicker and better. And the medical staff and the healthcare providers experience the satisfaction of being part of a care process where their patients are feeling and doing much better, faster, and their outcomes are improving. So the medical staff and the healthcare providers are also one of the beneficiaries. At the same time, the managers see their units deliver better care for substantially less cost, and the general public ultimately experience better care at a lower cost. So the presentation, my presentation will focus only on cesarean section and gynecologic surgeries. The goals of enhanced recovery after surgery for cesarean section is to help provide all women with evidence-based, patient-centered care using standardized, multidisciplinary approach that optimizes recovery from cesarean delivery and improves maternal and newborn outcomes. And the center to this goal is culture of critically examining and applying current knowledge through continuous process improvement and collaborations. And this process is a care pathway. It doesn't start during surgery, but it is considered as a continuum of care from preconception outreach, antepartum optimization, intrapartum care, including anesthetic, and concluding with postpartum inpatient care and outpatient support. It also by reducing variabilities in care and creating a specific evidence-based care pathway, maternal and fetal outcomes can be improved. The success of enhanced recovery after surgery programs for cesarean section program lies on interdisciplinary collaboration, not only for cesarean section, gynecologists, for every ERAS protocol. Interdisciplinary collaborations is the hallmark of enhanced recovery after surgery. This enhanced recovery after surgery for cesarean section pathway have been developed for scheduled cesarean delivery. However, many elements of the pathway can be applied to non-scheduled cesarean delivery. For in our practice, we use for scheduled or non-scheduled cesarean section, for elective and non-elective, for emergency cesarean section as well. And when you come to gynecologic surgery, different studies in gynecologic surgery have demonstrated significant improvement in length of stay, patient satisfaction, and decreased cost. So the essential components of surgical pathway include comprehensive patient education regarding goals and postoperative expectations. I think we are doing this in our practice all over the nation, and limited preoperative fasting that we are doing, and use of oral carbohydrate and electrolyte fluids prior to surgery. This is maybe a new for our setup. I will explain it later on. And multimodal pain control, including non-opioid analgesic agents and regional anesthesia, are very important and one of the good component of surgical pathway. And resumption of normal diet and activity immediately after surgery. This is also new, and we are not practicing this according to my observation. We are not practicing it, but during my practice, we resume normal diet as fast as possible in a patient who are undergoing gynecologic or cesarean sections. And I will discuss later its importance and how we are going to do it. And in its statement of ERAS, FIGO puts there are three main tenets of ERAS, and these are early feeding, euvolemia, and multimodal pain control. If we are practicing these kind of things in our surgical practice, our patient's satisfaction and outcome is going to better according to the FIGO's explanation on its ERAS paper. This is the general principles of enhanced recovery after surgery. So to show it's short by short explanation, in the pre-operative period, we optimize patients prior to surgery. For example, by counseling, by avoiding prolonged fasting, by carbohydrate loading. I will discuss carbohydrate loading later on. And also in the perioperative period, we have to reduce stress. Stress reduction is very important. For example, by optimizing fluid management, by maintaining hypothermia, by short-acting anesthetic agents, and also small incisions, or by avoiding or minimizing drains, and also by using multimodal opioid sparing analgesia. And in the post-operative period, protocolized normalization is very important to make the better outcome of our surgical intervention. For example, by early oral nutrition, early mobilization, and early removal of lines and drains. And we will discuss each point during a detailed explanations of the ERAS protocols. When you come to ERAS guideline for cesarean section, there are some preoperative elements, and the aim of these preoperative elements is to reduce the fasting periods, to engage patients and providers in the care plan and promote physical health optimizations. And when you are going to limit the fasting interval, I think we are practicing this in our country. Solids up to 6 to 8 hours prior to cesarean delivery, and clear fluids up to 2 hours prior to cesarean delivery. This is a new, and I will discuss it later on. And when we reduce we have to reduce aspiration risk while limiting thrust and starvation. And the American Society of Anesthesiology guidelines, they state 6 to 8 hours based on type of food ingested to put the patient's NPO. And a light meal or milk may be ingested for up to 6 hours before elective procedures requiring what form of anesthesia, whether general anesthesia, regional anesthesia, or procedural sedation and analgesia. And the type of anesthesia doesn't matter. And additional fasting times, 8 or more hours, may be needed in case of patient who took heavy meals. So when you come to the point of non-particulate liquid carbohydrate loading, so non-particulate carbohydrate drink up to 2 hours prior to cesarean delivery is recommended for non-diabetic women, and 45 grams of carbohydrate is recommended. In a Western setup, there is a special preparation to load this kind of carbohydrate in a patient undergoing elective surgeries 2 hours prior to surgery. In our practice, what we do is we give them tea or water, or they can take coffee, because we don't have this kind of preparation. But non-particulate juices, apple juice, mango juices can be used, but the problem is it's not studied well in different setups. But there are special preparation, as I said, in Europe and United States. And use of a carbohydrate-rich drink with low osmolality to enhance gastric impeding. And this intervention reduces maternal hypoglycemia and metabolic stress. And the other important point is patient education about surgery. The expectation of the outcomes is very important. Of patient education is very important. I think we are doing it in our daily practice. And the other one is lactation and breastfeeding preparation and support is very important. After all, if patient undergoing cesarean section, if she's able to breastfeed, breastfeeding and lactation is very important point to be discussed prior to surgery. And support of the golden hours to help the first 1 hour, or to help the woman initiate breastfeeding within 1 hour of birth is very important. So we have to initiate breastfeeding as much as possible after extraction of the baby from the abdomen. And the other one is hemoglobin optimizations, and all women should be screened for anemia. And I think this is our daily practice in the antenatal care. And when a woman with iron deficiency anemia should be treated with supplemental PO, or if she is refractory for PO, we can give her IV iron in addition to prenatal vitamins. Whenever we treat patients for anemia, we are not we should include prenatal vitamins at the same time. So it's not only to give iron and folic acid, but prenatal vitamins are very important. And in endemic areas like ours, if the prevalence of preventive anti-emetic treatment is recommended for pregnant women after the first trimester as part of worm infection reduction programs. According to WHO, if the prevalence of anemia is above around 40%, and if the prevalence of intestinal parasites above 20%, any pregnant woman should be dewormed, whether she's symptomatic or not, after the first trimester. And preventive chemotherapy or deworming using single dose albendazole 400 milligram or mebendazole 500 milligram is recommended as a public health intervention for pregnant women during the antenatal care. According to WHO 2016 antenatal care for positive pregnancy experience publications, they give this albendazole, mebendazole at 20 weeks of pregnancy. So we are practicing this in our setup. And the other one is WHO safe childbirth checklist. and it's not included in any of the ERAS protocols, but in our practice, we use the WHO Safe Childbirth checklist to reduce the maternal mortality and morbidity. As you know, this is one of the best interventions that the WHO initiated for the patients who are going to deliver in healthcare institutes. And intraoperative ERAS elements, and these elements, their aim is to optimize fluid management. So we have to be very important on managing patients with fluid, to prevent spinal anesthesia, induced hypotension, to minimize intraoperative nausea and vomiting, to initiate multimodal analgesia, and support early breastfeeding and maternal-infant bonding. The other point is surgical site infection reduction bundles. These are very important bundles to reduce the surgical site infections. These are antimicrobial prophylaxis, skin preparation, avoidance of hypothermia, and avoiding surgical drains. We don't put drains during cesarean section, but in gynecology surgery, in other surgeries, avoiding surgical drains is very important, and reducing perioperative hyperglycemia. If we are able to manage patients on these issues, the risk of surgical infection is going to be very, very low. And the other point is the WHO surgical safety checklist. This safety checklist should be filled before induction of anesthesia, and this is not included in any of the ERAS protocols, but as part of surgical management, we practice this in our setup. And this surgical safety checklist should be filled prior to initiation of anesthesia, before induction of anesthesia. And according to WHO, it reduces the maternal any surgical mortality, morbidity by 20 to 30% by using this surgical safety checklist. And regional anesthesia is a preferred method of anesthesia for cesarean delivery as part of an enhanced recovery protocol. And I think most of the cesarean section in our setup being done using regional anesthesia. And the other point is prevention, to prevent and treat spinal anesthesia-induced hypotension. And the goal of this treatment and prevention is to prevent intraoperative nausea and vomiting after spinal anesthesia, and maintain uteroplacental perfusion, and which is optimally managed with prophylactic vasopressor infusion with phenylephrine and norepinephrine. I don't think we have this drug in our setup. And left uterine displacement and intravenous co-loading. When we use intravenous co-loading, we use it with the prophylactic vasopressor, but giving only fluid doesn't improve the hypotension created by spinal anesthesia. But we can do left uterine displacement and at least lower extremity compression to reduce this hypotension. And the other one is maintaining normothermia. We should use active warming. For example, we can warm the IV line, and also we can maintain the room temperature around 22 degrees Celsius. And this warming should be started preoperatively. We know most patients suffer from hypothermia in our settings, but we have to reduce the incidence of hypothermia in a patient undergoing cesarean section, so that they are going to avoid the risk of surgical site infection. And the other one is optimal ultrasonic administration for the reduction of hypothermia. So we have to use the lowest effective dose of urotonic necessary to achieve adequate uterine contraction to minimize their side effects. The other important bundle is antibiotic prophylaxis. So it should be given prior to skin incision, and for antibiotic prophylaxis for cesarean section, a single dose of first generation cephalosporin or penicillin should be used in preference to other classes of antibiotics. This is recommended by different ERAS protocols, and in most of the time we don't have the first generation cephalosporin in our setup. So when we don't have cefazolin, the other options that we use is we can give ampicillin subluctam prior to surgery. And ampicillin subluctam, most of the time it's not available in our setup, but a very effective regimen that is shown in the left lower, in the right lower corner of the slide. You can see metronidazole, 500 milligram IV with gentamicin. When we give gentamicin, it is 5 milligram per kg stat. So we can use metronidazole and gentamicin, and I am practicing this for the last 2.5 years almost with enhanced recovery after surgery. It is one of a good alternative. And in its recent publications of up to date in 2021, they give clindamycin and gentamicin as well. If the patient is, if there is no cefazolin, or if there is allergic to penicillins. And in its very recent recommendation, WHO recommendation on prophylactic antibiotics for women undergoing cesarean section, it was published recently. And in that publication, they say for antibiotic prophylaxis for cesarean section, a single dose of first generation cephalosporin or penicillin should be used in preference to other class of antibiotics. And in their statement, they say the evidence suggests that third generation cephalosporins may be less effective than penicillin for these indications, and therefore suggests that this class of antibiotics should be avoided. I know in most of our practice, people are using ceftriaxone, third generation cephalosporin, but we should no more use ceftriaxone for surgical prophylaxis. It's not effective, and it's not recommended by any of the organizations. So we have to avoid using ceftriaxone. This is a point that I should stress, and people should not use ceftriaxone for surgical prophylaxis. In a Western setup, if a woman is in labor or with rupture of membrane, addition of azithromycin 500 milligram IV, it confers additional reduction in postoperative infections. We don't have azithromycin IV in our setup, so we don't use these antibiotics. The other one is skin preparations. So in their recent publications, WHO pointed out that the choice of antiseptic agents for applications of for the prevention of infection in cesarean section, they say that the use of alcohol-based chloroxidine gluconate for skin preparation prior to elective or emergency cesarean section is recommended. So in that paper, they emphasizes on the importance of chloroxidine gluconate. In most of the publications, they elaborate that chloroxidine gluconate 2%, sometimes 4% with 70% isopropyl alcohol is recommended for skin preparation in elective or emergency cesarean section. But I don't think we don't have this kind of preparation in our setup. So there is another alternative. So if we don't have chloroxidine gluconate, we can use other antiseptic agents such as povidone iodine can be considered for a suitable antiseptic agent for preoperative skin preparation. Although it is not as effective as alcohol-based chloroxidine gluconate. And I have seen some people using tincture iodine to do cesarean section or gynecology surgery, but this tincture iodine is not recommended in any of the guidelines, and in side effects, the irritation is very high, so I think we should avoid using tincture iodine. Povidone iodine is cheap and available in all over the nation, so we can use that. And the other point is, and also vaginal cleansing or cleaning the vagina prior to cesarean delivery, whether it's an elective or emergency cesarean section, is very important as part of reduction of postpartum surgical site infection and postpartum endometritis. And WHO recommends on vaginal preparation with antiseptic agents in women undergoing cesarean section in their recent publication. And they say vaginal preparation with chloroxidine gluconate or povidone iodine immediately before surgery or before cesarean section is recommended. So in our practice, what we do is we cleanse the vagina with povidone iodine after catheterization in the operative table, which reduces the surgical site infections. The other one is intra and post-operative nausea and vomiting prophylaxis and treatment. So one of the things that we do is we should use prophylactic vasopressor infusion to decrease hypotension associated with intraoperative nausea and vomiting. I don't think we have these agents in our country. The other one is we have to limit or avoid uterine exteriorization and abdominal saline irrigation by surgeon. So in our practice, what we do is we repair the uterus while it is in the abdominal cavity. If there is bleeding, if there is some kind of difficulties, we exteriorize the uterus. But most of the time, we close the uterus in situ the abdomen. And this is also recommended in different guidelines or protocols. It reduces the patient's hypothermia, and also it reduces intraoperative nausea and vomiting. And a combination of at least 2 prophylactic IV antibiotics with different mechanism of actions are also recommended for the prevention of nausea and vomiting, like ondansetron, dexamethasone, or metoclopramide. Whatever you do, you can do this kind of medications. And this is derived from the EFL criteria. This EFL criteria puts 4 risk factors. For example, postoperative opioids, non-smoker, female gender, and history of postoperative nausea and vomiting or motion sickness. When you see most of the cases, our mothers are non-smokers and they are female gender by default, most of them they get 2.2. When there is this point is 2, there is 39% of postoperative nausea and vomiting. So in this case, we have to give at least 2 prophylactic antiemetic agents. For example, we give ondansetron and dexamethasone. In our practice, we give ondansetron and dexamethasone before cesarean section. And antacids and histamine H2 receptor antagonists should be administered as pre-medication to reduce risk from aspiration pneumonitis. In our setup, we give cimetidine because we don't have non-particulate antacids. We don't give antacid, but we give cimetidine prior to cesarean section. The other one is initiation of multimodal analgesia. And non-opioid analgesia started in the operating room unless there is contraindications, for example, acetaminophen or paracetamol IV or PO before or after surgery. And consideration of local anesthetic, continuous wound infiltration or regional block is recommended. In our setup, what we do is we infiltrate the fascia and the peritoneum with lidocaine prior to the closure of the fascia. And in different publications, they elaborate that this kind of intervention reduces the postoperative PAIL scores. It reduces the postoperative use of opioid analgesia. So it is one of a good practice, and it should be practiced in our setup. And the other one is promotion of breastfeeding and maternal-infant bonding. Skin-to-skin contact should occur as soon as possible in operating room as appropriate based on maternal and neonatal condition. And skin-to-skin contact intraoperatively supports the golden hours of breastfeeding initiation within 1 hour of birth. And we initiate, in fact, breastfeeding intraoperatively. And the other point is delayed cord clamping. ACOG, RCOG, and WHO recommend a delay in umbilical cord clamping in vigorous term and preterm infants for at least 60 seconds after birth. WHO recommends between 60 and 3 minutes, but the other organization recommends at least for 60 seconds, whether they are preterm or term. And the benefits are, for term neonate, it improved iron stores, and it has developmental benefits. And in preterm neonate, it improved transitional circulations, it reduced a need for transfusion, and low risk of necrotizing enterocolitis and intraventricular hemorrhage. But there is some risk of jaundice requiring phototherapy when we are going a delay in umbilical cord clamping, but that's not that much significant. It doesn't increase the maternal risk of blood loss or any risk of transfusion. And also we can administer the oxytocin after the delivery of the baby. And delayed cord clamping should be deferred in certain situations, for example, maternal instability, fetal or neonatal needs for immediate resuscitation for obvious reasons. And a very important point is when we have maternal infection like HIV or hepatitis, and RH incompatibility, whether the woman is synthesized or unsynthesized. These are not a contraindication for delayed cord clamping. In its paper, WHO explains about the importance of delayed cord clamping in a woman with HIV and hepatitis B, and they assure, according to their explanation and their experience, that delayed cord clamping should not be avoided in women with maternal infection, and also in RH incompatibility. In its explanation about cord clamping, the American College of Obstetrics and Gynecology clearly explains the importance of delayed cord clamping in a woman with RH incompatibility. But our guideline is against this. But I am practicing that whether they are RH negative or HIV or hepatitis infected, we delay the cord, whether we are doing cesarean section or vaginal delivery. The other one is postoperative ERAS elements, and the aim of these postoperative elements include minimizing post-cesarean metabolic stress by early feeding, by promoting early mobilization, by providing multimodal analgesia, and removing physical early mobilization barriers, and facilitate hospital discharge. Early oral intake, for example, we can give water, tea, or coffee within 60 minutes of admission to post-anesthesia care unit, or we can saline lock the IV early once the oxytocin infusion is complete and the patient is tolerating fluids and urine output is adequate. And also, we should advise patients to take regular diet, ideally within 4 hours of post-cesarean, as tolerated. So in our practice, we initiated them within 2 to 4 hours of cesarean section. We initiate them with normal diet as they tolerated. In Western setup, like in Europe, they initiate regular diet within 2 hours after cesarean delivery. And early oral intake leads to accelerated return of bowel function. This is a very important point. Our thinking is it is going to delay bowel function, but in fact, the opposite is the truth. It accelerates return of bowel function. And also it reduces hospital length of stay. There is no increased rate of complications. This is a very important point that is discussed with American Society of Anesthesiology in obstetric gynecology. They say there is no risk associated with early oral intake, and also it doesn't increase the risk of postoperative nausea and vomiting. Our fear is the patient may have nausea and vomiting if we initiate them with early oral intake, but it's not associated with increased risk of postoperative nausea or vomiting. And also it reduces postoperative catabolism, it improved insulin sensitivity, and it reduces the surgical stress response. So this is going to affect the outcome of our patient. The other very good point is glycemic control. Patients with diabetes, ideally they should be scheduled as first in case of the case of a day, and maintaining normal glycemia less than 180 is recommended. And any hyperglycemia above 180 is associated with poor outcomes, including infection and delayed wound healing. This is taken from Journal of Anesthesiology, and in that case, they recommend that correctional subcutaneous insulin scale for patients in the day of surgery and postoperative surgical wards. And if you use this correctional scale, the risk of hyperglycemia, the risk of wound infection and wound healing will be improved. In our setup, we do random blood sugar every 4 hours, and we put the patient in correctional subcutaneous insulin with regular insulin. The other one is early mobilization. So ambulation should occur soon after return of motor function that we do in every setup in our country. So this early mobilization, it decreases insulin resistance, muscle atrophy, hypoxia, venous thromboembolism, and length of stay. And ambulate only after adequate return of motor function after spinal anesthesia. And we have to remove the barriers to early mobilization, like intravenous lines, urinary catheters, poor pain control. If you control the pain, patient can ambulate easily, avoiding sedation, nausea, vomiting, dizziness. it improves the patient's mobilization. The other one is we have to promote resting periods, and we have to optimize sleep and rest by limiting unnecessary interventions. For example, we can give time-scheduled oral analgesics, but follow appropriate post-operative monitoring. This is a very important time to detect any complication if it arises. And also fatigue, it potentially negatively impacts the cognitive function. It increases depression, it worsens pain, it impairs maternal-infant bonding, and it may increase risk of respiratory depression. And the other point is to promote return of bowel function by minimizing opioid consumption. We can consider also chewing gum and coffee. The other point is early removal of urinary catheters. Urinary catheter should be removed 6 to 12 hours in postpartum period. In different ERAS protocols, in Western setup like Europe, urinary catheter should be removed immediately after cesarean delivery if they placed it during surgery. Its benefits include improved ambulation, shorter lengths of stay, lower cost of symptomatic urinary tract infections. And the other point is the venous thromboembolism prophylaxis. You have to follow our institutional protocols. Cesarean delivery it approximately doubles the risk of venous thromboembolism, but in otherwise healthy patients, the absolute risk is very low, but we have to consider this in our cesarean sections. And multimodal analgesia, these analgesic protocols include scheduled non-steroidal anti-inflammatory drugs, scheduled paracetamol, scheduled tramadol or local anesthetic techniques that I explained it before. For example, in our setup, what we give is paracetamol, 1 gram IV every 6 hours, tramadol 50 milligram IV every 6 hours, and ibuprofen PO 800 milligram every 6 hours. And it is very successful in managing the pain in post-op patients. This multimodal analgesia, it should be used to reduce pain, improve mobilization, it limits IV opioids in recovery, and it reduces in-hospital opioid use and decreases opioid use after discharge. So opioids are associated with nausea and vomiting, sedation, fatigue, ileus, constipation, mucus, and addiction risks. It is known that people use pethidine for post-operative pain, but the American Pain Society doesn't recommend it to be used for pain management. And this pethidine has this kind of side effects. I think we should avoid using pethidine. So in our practice, we are not using any form of pethidine in the patient in the post-operative period. So this multimodal analgesia, necessary anti-inflammatory drugs and paracetamol, it decreases opioid use or side effects by 30 to 50%. And whenever we are using pain management, it is recommended to use WHO pain ladder principles. And the other one is to facilitate early discharge. No need to keep patients in the ward unless there is anything, any problem. So we have to standardize discharge planning and coordinate care should be started pre-operatively. And breastfeeding support is very important and it should start immediately after birth by offering skin-to-skin care and continue throughout hospitalization. So initial skin-to-skin contact should continue uninterrupted until completion of the first breastfeeding. It should be started intraoperatively. For formula-fed infants, initial skin-to-skin contact should be continued uninterrupted for at least 1 hour. And after the initial period of skin-to-skin contact, mothers should be encouraged to continue this type of care as much as possible during their hospital stay and at home. And also they should be provided with lactation consulting and educational materials using the 10 steps of successful breastfeeding by baby-friendly hospital initiatives. When you come to the ERAS guidelines for gynecologic surgery, in the preoperative period, we have to educate patients and we have to counsel them, and with dedicated preoperative counseling. I think it is obvious. And the other is preoperative optimization. That means if the patient is a smoker or alcohol consumer or alcohol abuser, they should stop this 4 weeks before surgery. And if there is anemia, it should be actively identified, investigated, and corrected preoperatively, that we are practicing in our daily practice. And the other one is preoperative bowel preparation. These should not be used routinely, even when bowel resection is planned. Even in colorectal surgery, in enhanced recovery protocols, they don't do bowel preparation. And preoperative fasting and carbohydrate treatment that I explained during cesarean section is also very important. And clear fluids should be allowed up to 2 hours and solids up to 6 hours prior to induction of anesthesia. And carbohydrate loading reduces postoperative insulin resistance and should be used routinely. And the other point is pre-anesthetic medications. People give some kind of sedations to alleviate anxiety, but it should be avoided. And thromboembolism prophylaxis if there is no risk of significant bleeding. So this venous thromboembolism should be started before start of surgery. In case of cesarean sections, we give this prophylaxis almost 8 to 12 hours after surgery. But in case of gynecologic surgery, it should be started a day before surgery. Patients on hormonal replacement therapy or oral contraceptive, they should discontinue the medication or they should consider other alternative before surgery. And there are this modified Carpini score is one of the modalities that we use to score patients for the risk of venous thromboembolism. This is for the general surgical patients, but it can be used for gynecologic surgeries. So these risk factors are calculated and the patient's risk is identified. Then if there is a moderate or high risk, the patient should be initiated with mechanical prophylaxis and also with medications. And the other point is surgical site infections that we discussed, bandits that we discussed in cesarean sections, antibiotic prophylaxis, skin preparation, avoiding hypothermia, and avoiding surgical drains. Whenever we do lymphatic pelvic lymph node dissections, this surgical drains should be avoided, and reducing perioperative hyperglycemia is very important. The other point is antimicrobial prophylaxis and skin preparation. IV antibiotic should be administered routinely within 60 minutes of skin incision. An additional dose should be given during prolonged operations or if severe blood loss occur intraoperatively. And this is also taken from up to date 2018. They use first and second generation cephalosporin for elective procedures. As you see in the left lower quadrant, in the right lower quadrant of the slides, there is metronidazole, gentamicin, and we can use this even in gynecologic surgeries. And in its recent recommendation on antibiotic for surgical for prevention of antibiotic prophylaxis, WHO states that this guideline development group at WHO, they noted that first generation cephalosporins are preferred antibiotic class for prophylaxis in general surgery as part of effort to contain antimicrobial resistance. So this can also works for gynecologic surgery. So we have to avoid ceftriaxone. So hair clipping is preferred if hair removal is mandatory, and shaving is not recommended prior to gynecologic surgery. And chloroxidine alcohol is preferred to aqueous povidone iodine solution for skin cleansing. So, but if we don't have chloroxidine alcohol, we can use the povidone iodine. The other point is vaginal cleansing. If the patient is going to undergo hysterectomy, vaginal cleansing with povidone iodine immediately before hysterectomy is recommended to decrease the surgical site infections. So in our practice, what we do is after catheterization, we clean the vagina with povidone iodine for 30 to 60 seconds. And intraoperatively, the WHO surgical safety checklist should be filled. This is the checklist. It reduces mortality and morbidity. And the other one is standard anesthetic protocols. For example, short-acting anesthetic agents should be used to allow rapid awakening, and ventilation strategy using tidal volumes of 5 to 7 ml per kg with PEP of 4 to 6 centimeter of water should be employed to reduce postoperative pulmonary complications. And the postoperative nausea and vomiting prophylaxis, it is the same as with cesarean section. So antacids or histamine H2 receptor antagonist should be administered prior to surgery. The other one is if it's available, we should use minimally invasive surgery. So we minimize the surgical incision as appropriate. The other one is nasogastric intubation. So routine nasogastric intubation should be avoided. If it is placed for some reason intraoperatively, it should be removed before reversal of anesthesia. Then the other point is preventing intraoperative hypothermia. It is the same with the cesarean section. So maintenance of normothermia with suitable active warming device should be used routinely, but in our setup, we should keep the operative room warm. And perioperative fluid management, very restrictive or dual use of fluid regimen should be avoided in favor of euvolemia. And in the postoperative period, prophylaxis against thromboembolism should be initiated. At least we can do early ambulations. If the patient have surgery for abdominal or pelvic malignancies, this prophylaxis should be extended at least for 28 days. But in other cases, if the patient starts to ambulate, we can discontinue the thromboprophylaxis. Also during cesarean section, once the patient starts to ambulate, we can discontinue the prophylaxis. And in the postoperative fluid therapy, intravenous fluid should be terminated within the first 24 hours as much as possible. In perioperative nutritional care, a regular diet within the first 24 hours is recommended. And we start the patient like cesarean section whenever they have gynecologic surgery. And preventive postoperative ileus, for example, we can use postoperative laxative, should be considered. We have to use it. We can use liberal use of laxatives, and also we can use chewing gum and coffee. They can be considered. And the other important point is postoperative glycemic control. We have to maintain blood glucose less than 180, and if the level is above 180 or 200, they should be treated with insulin infusion, like correctional subcutaneous insulin scale, and we have to monitor blood glucose to avoid hypoglycemia. And the other one is postoperative pain analgesia. Multimodal approach to analgesia should be adopted, like anti-inflammatory drugs, acetaminophen, dexamethasone, unless there is any contraindications. And surgical site infiltration with local anesthetic is very important, that I discussed during cesarean sections. The other one is peritoneal drainage. It's not recommended in patients undergoing lymphadenectomy or bowel surgery. And the other one is urinary drainage. So urinary catheter should be used for a short period, for example, less than 24 hours. So we should remove the catheter as early as possible. And the other one is early mobilization. Patients should be encouraged to ambulate within 24 hours of surgery. So this is going to be the end of the presentation, and by doing this kind of intervention, it is known that it reduces different complications, and I am practicing in my practice, and it is rewarding. And these are the references that I have used to prepare this kind of presentation, and thank you.